Welcome to Back from the Abyss. I'm Dr. Craig Heacock. We do 3 types of episodes on Back from the Abyss. Personal stories, my monologues and musings, and finally interviews with experts who offer something particularly interesting to me, and I hope to all of you. Today's episode falls into the expert category, and can I say wow to this episode? My guest is Dr. Jennifer Gaudiani, an internist and author of the book Sick Enough, A Guide to the Medical Complications of Eating Disorders. Dr. G is a nationally recognized expert on eating disorders and the founder of the Gaudiani Clinic in Denver. I learned a ton from Dr. G, and I've been really looking forward to sharing this with all of you. This is a wide-ranging discussion that I think stretches far beyond eating disorders and gets to the heart of some of our most sensitive cultural biases and beliefs. I'm really delighted to be here in Denver at the Gaudiani Clinic with Dr. G, Dr. Jennifer Gaudiani. Thanks for having me down.
I'm so happy to have you here. I'm so glad to know you.
I know.
Now that I know you, we're going to be in touch.
Now we're buddies, yeah. I heard you on the Psychiatry and Psychotherapy podcast, and I just said, oh my gosh, this is one of the most interesting episodes that Dave's ever had. And at one point you said you were in Denver. I said, yes. Because unlike most podcasts, which record distance on Zoom, as listeners know, I do all these in person. So contacted you and threw the stuff in the Subaru Outback and drove down here, and it's wonderful to be here.
Amazing. I love this format. I haven't done it before, but it's really, really nice because I sort of feel like I'm just having lunch with a friend, but we have microphones and headphones.
I know. That's the special sauce. Yeah. I just want to jump right in. I have so many things that I want to talk about. As I was just saying before we started recording, a lot of the things we talk about on Back from the Abyss, I feel like I'm more or less an expert in. Eating disorders, no. I treat a lot of people with eating disorders. I'm very interested in them. I've tried to do my best, but I really feel like I fail regularly with those patients. And so I'm actually thrilled to be here.
You are not alone in feeling that you fail regularly with patients with eating disorders. I often feel I fail my patients too. And I think that's actually part of the relationship. It's probably part of the therapeutic work. And it's something that helps us feel compassionate for the fact that they also feel like they're failing themselves all the time. I sometimes talk with my patients about the fact that having an eating disorder is so exhausting because at any given time, if you're listening to your wise self, you are disappointing your eating disorder self. And if you're listening to and acting on your eating disorder side, you're disappointing your wise self and your true values and goals. And most of my patients are individuals who hate disappointing anyone. So given the fact that they're basically in a constant cosmic battle of disappointment all day long, man, that is so, so tiring. And it can make them feel like failures, and it can contribute to the team feeling like, oh my gosh, I don't know exactly where we go next. But that's when you just say like, look, I'll hold your hand and I'll hold the lantern, and let's keep walking down the fucking tunnel until we find a light.
I love that. I want to start with the etiology, the cause of eating disorders. And I'm very interested in this. And again, I know this is very complicated because, what causes depression? Well, how long do you have? What causes addiction? I mean, how much time do you have? But I'll give you my sense of what causes eating disorders, and I want to hear you go more deep on that deeply. My sense is, and again, eating disorders is a big tent, but my sense is that it's some combination of temperament and familial environment and social expectations and OCD tendencies and trauma. Some mix of all that, but I'm curious what your thoughts are on that.
I agree completely with you. Eating disorders are the classic ultra-complex biopsychosocial entity. And anyone who tries to sell you a line that they're just a brain disease, that they're just a body disease, that they're just a mental illness, that they're just a starvation disease, that they're just a feminist disease, that they're just a social media disease, we can't use the word just when it comes to eating disorders because they are all the things. So exactly as you said, they are going to have temperamental bases that are hereditary. And we do inherit temperamental traits from our parents. those often, but don't exclusively, include being the kind of person who is very intense, perfectionistic, exquisitely sensitive to the world. I sometimes feel like my patients are sea anemones that just get punched in the tentacles by things that other people swim by, but they just get boom, right in the tentacles all the time, and it is just excruciating. They tend to be more anxious, harm avoidant, and they tend to be just the most delicious humans you can possibly imagine. I love my patients so much. And so you take an individual like that and you then begin to raise them in the world. And so many of my patients tell me, I love my parents so much, and it's very, very, very clear that parents and carers do not cause eating disorders. But what my patients may experience because of just how their unique coin is formed, and I talk about the bright, glowing side of their coin and that flip side that can be fucking dark and hard and just more difficult to live with, equally bright as dark, that they may feel that they're not served by their families of origin. Not because anyone wasn't trying or had the greatest of intentions and love, but just a sense that this unique little human had different needs than were able to be met in some key ways. Maybe when they would weep over the plight of the environment, their family would be like, you know what? You've got to get a grip. We also believe that global warming is a problem, but come on, dude, you got to be a little tougher than this, which is not a wrong thing to say. And anyone who's a parent has been like, oh, yep, I have totally said that before. But for that little person, what they might hear is, you're too much. You're too much. You can't have those feelings. You got to button it up. You're feeling too much, and I don't know how to deal with you, and it's problematic. So that little human, grows up, and I'm saying little human, and I don't mean to be condescending. The majority of people, I think, feel the roots of their eating disorder in their youth. Certainly some people can de novo develop them later on. And then they're growing up in a society that is wildly fatphobic. And even when they're in families who have the best of intentions, in our family, we don't say the word fat because, we don't want to be mean to anybody. Interestingly, even that statement is actually fatphobic because words that are unspeakable are reserved for Voldemort. When it's he who cannot be named, it means that there is something really problematic about it. So, we're raising our children because we want them to be well and vibrant. We want them to be independent. We would love them to be accepted by the world in general and to have as little struggle as possible. And so, especially where parents come into it with their own eating pathology or what they heard their own parents and society say, they're raising kids with beliefs about healthy food and junk food and about, what kind of bodies are healthy or not healthy or acceptable or commendable or problematic. And they do those in such incredibly subtle ways that no one even thinks about it because diet culture is the water cooler talk in our country, in our world. And so kids start to hear at home that certain bodies are acceptable and certain aren't. And they might evaluate their own bodies because a lot of my patients are just exquisitely aware of themselves by contrast and comparison with the rest of the world from an early age. And, they go on to be surrounded by peers and their peers' families, and then eventually the megaphone of society's ills, which is social media. It's not the cause, but it is the megaphone. And they may indeed experience trauma. They may have a variety of adverse childhood experiences that make them, in their exquisite sensitivity and without a lexicon yet built to say, I know how I feel, I know how to soothe that feeling, I honor the fact that I need soothing, and I'm going to go take care of myself the way I need to. I mean, what child is hatched with that? Most of us adults aren't. But they may find that disordered eating behaviors provide a protection. And so when my patients come in and we start to talk and they tell me the narrative, the story of their experience in their bodies, because I was an English major and I love a good story, usually I try to find a way to ask them the ways in which their eating disorder was protective, was their hero, was trying to do right by them. Because when clinicians automatically jump to the idea that an eating disorder is an abusive partner, that it's a tormentor, that it's a devil to be exorcised, all of those things can apply at times. But I think it's more compassion-inducing and right, narratively sound to say, when shit was going down when I was a child and I could go into the pantry and just eat, it soothed me. I was doing something that felt good in my body, and I was by myself, and it numbed me out, and I didn't think about all that stuff. And that same thing might be said for food restriction, or it might be said for purging, because the eating disorder is a protector. Or, as body sizes influence how people develop eating disorders, someone might have said, I was the chubby kid who was teased, and so restricting food made me safer in my body. Or they might have said, I was sexually abused at an age when my body looked like this, and my eating disorder allowed me to change my body's appearance radically so that I was not viscerally reminded of the body I was in when I was harmed. There are so many ways in which the eating disorder starts out as a protector. And it can even start out as a protector that's an early warning system. I sometimes think of eating disorders as the final manifestation of distress that has been brewing without capacity to ease it for a long, long time. By the time someone is doing eating disorder behaviors, they've been suffering a long time. They've been wanting to feel things they can't express. Mm-hmm. They've been wanting to take solace and rest in ways their temperament or their family or their society around them hasn't allowed them to. And you see all the time, I know in your practice, people whose mind will finally be like, I'm going to bench you. If you can't take care of your needs, I will bench you. And that's what the eating disorder does. It manifests, in some cases, when patients lose weight in their eating disorder, a body that is evidently suffering.
What do you think it says about etiology that eating disorders are so much more common in women? I mean, is that, how much of that is a comment, or is it a commentary on culture and what expectations of women versus the fact that women have twice as much clinically significant depression and anxiety as men, versus hormonal things, versus maybe more tendency towards perfectionism and people pleasing? Or, I mean, I can imagine a bunch of different causes, but I treat men with eating disorders, but it is much, much less common than women. It seems like, amidst this stew of potential, causative factors, there must be some things that are putting girls and women at, much higher risk.
Yeah, that's a great question. It probably varies depending on the eating disorder diagnosis. And I think the DSM-5 sucks for the most part. And but if we look sort of in broad categories, binge eating disorder, which is the most common eating disorder, is actually reasonably evenly divided among men and women. Mm. And so, and that's not surprising because we live in a culture that recommends people diet or restrain their food, and biologically we're set up to binge when we do that, and so it can set people down a whole road. So the fact that there's an evenness amongst men and women on that is not so surprising. With bulimia nervosa, it's a little more disparate. There are more women than men, but not as strongly as there is in anorexia nervosa. And there's still, even though the numbers are probably 10% men to 90% women in anorexia nervosa, that's still a shitload of men, in the greater population. When you apply 10% to the sum total of people with it, that's a lot of people. And so what I would say is, I will admit it, a feminist. And for me, that means that we look at things through a lens that tries to understand historically how women have been expected to behave in the world in order to be safe and accepted. So the tendency for women to be told to deprive yourself, to fail to meet your needs, to live with a certain degree of discomfort in order to show up properly, whether that's with sexual appetites or food appetites or rest appetites or independence appetite. All of these things through history, women have been asked to really tamp down what they want and show up like everyone else or like the norm. And so when we have that history, we also have a fascinating history of women actually asserting power through starvation. There's a fascinating religious history of women who later become saints who fasted and were felt to be holy as a result of of abstaining so profoundly from what their body's needs were. And so in, complex church traditions that are not always the most women-oriented, those women were ultimately vaunted and given power, or they were given power because, they were so sick they couldn't marry. These were some ways of getting out of the structure of what women were expected to do. And so I think that remains today. I think that there's a lot of fear about what it means to become an adult and to have an adult's body and adult's responsibilities in a society that sometimes doesn't tell women, because sometimes it's not true, or sometimes they actually do have the capacity and no one tells them, you can adult however you want to. There are undeniably privileges given to women who do certain things, and you could choose differently if you wanted to. So there's a huge complexity, but I mean, body image, body pressure, the fact that there is truly no body a woman can be in at any age that is above reproach shows what a quagmire we're in.
I wonder if anorexia is a different beast. And let me preface this by saying, for example, with bipolar disorder, that's a huge tent. It's a huge spectrum. I think of bipolar disorder kind of like skin cancer. Like it's this giant. There's so many manifestations. But in the core of the bipolar tent is what we call bipolar 1, or what used to be called manic depression. And it is a different beast. Manic depression responds far better to lithium. It has different kind of heritability. It looks different. It is clearly a different thing. We call it, bipolar 1, 2, NOS. But anybody who treats this knows that bipolar 1 is a whole separate beast. And my sense is that, in this huge tent of eating disorders, there's complicated etiologies and biopsychosocial factors, and that maybe there's this thing, anorexia nervosa, which is different. Like it seems more lethal. It seems more delusional. This idea of anosognosia, where patients don't recognize that something's wrong with them. That's again, all these prognostic. As people get sicker and sicker with anorexia, they don't want treatment, and they just seem to get more delusional. So I'm just curious about that. If that resonates with you, that anorexia is actually a different kind of thing, or do you see it more just on the same kind of spectrum?
No, I think that's right. And I want to be cautious in how I answer this, because those with eating disorders in general have a tendency to compare themselves with others and to feel themselves wanting, to feel not sick enough, which is the title of my book, Sick Enough, a guide to the medical complications of eating disorders. And so anyone who's listening to this who has or has people they love with bulimia or binge eating disorder, by no means do I think that anorexia is sort of the worst or the most impressive or the most, whatever. I do think it is different in interesting ways. And it's important to note as well that DSM fails us again here, because when people think about anorexia nervosa, they think about extremely emaciated, young, white, able, cis, het people. And it's not, of course, that there aren't plenty of people who meet that set of descriptions. But DSM-5 would have us believe that anyone who's in a non-emaciated body, but who's distorted, who has all the same beliefs on all of the different scales one measures psychological parameters in eating disorders, who engages in exactly the same kind of restrictive behaviors with or without purging, overexercise, that has to be diagnosed as a completely separate entity called atypical anorexia nervosa. But the truth is that from my perspective as an internist who's done this for 16 years, they are the same. They just don't, one of them happens to have genetics that gets really underweight, and one of the group happens to have genetics that protects their body weight or raises it even in the face of caloric restriction. So if we look at the sum total of individuals who have anorexia nervosa and atypical anorexia nervosa, and I'm now going to elide them both, there is something different. There is something that may start out different in the temperament of the person for whom complete restriction of joy, of satisfaction, satisfies something, numbs in a way that feels protective, punishes in a way that feels appropriate to how the individual feels about themselves, often in the context of having survived trauma. But additionally, there's the factor of biology and starvation. Because while restrictive eating is a part of almost all of the eating disorders, it's really in those who persistently undernourish that they end up in a physical state that is almost syndromically similar to what we see in certain chromosomal disorders. Are you familiar with the Minnesota starvation experiment? Mm-hmm. Can I briefly go over it?
Yeah, please do.
So in the 1940s, a group of conscientious objectors who wanted to serve their country but did not want to go to war volunteered to serve in an experiment run by Ansel Keys in Minnesota.
They should have gone to war.
They should have gone to war.
This experiment was so awful.
It's so bad.
It's so awful. Yeah.
So Dr. Keys wanted to observe what happened physically to young, healthy men when they were starved, because there was a vested interest in understanding what was happening in prisoner of war camps and in concentration camps. So these young men volunteered, and they started out in a washout period of a good 6 weeks of nice, wholesome eating, 3,500 calories a day, hanging out, doing their thing, just living and eating well. And then they went into a restrictive phase of the experiment when they ate as few as 1,500 calories a day. And whenever I read that fact, I'm struck by the sad truth that so many people who watch a lot of social media or really just live in the world believe that 1,500 calories a day is an adequate amount of food each day. But that's what these guys were doing in their starvation phase. And they lost a lot of weight, and Dr. Keys made commentary on all the physical things that happen in their bodies. What he didn't expect was the psychological changes. During the restrictive phase, these guys became deeply depressed, withdrawn, socially isolated, overwhelmed by groups. When they would be allowed to walk into town, they would press their faces against the diner window and record in their journals that they felt that the diners were disgusting and gluttonous as they ate the normal meals that they were eating. And when these guys, some of them became addicted to chewing gum, they really were obsessed with food all day long. They wanted to read cookbooks. They wanted to talk about food, and they couldn't stop thinking about it. And then when they began to be refed, they got very weird about food. They would sometimes store food in their pockets. They would cut it into tiny pieces and take 2 hours to eat what used to take them 20 minutes. They were stereotypically behaving like people with anorexia nervosa. And these weren't people who were genetically primed in, the anxious traits, the neurotic traits to sort of develop it. These were just dudes. And at a time when there was still diet culture, but much less than there is now. So there is something that happens to our brains when we don't eat enough for a certain period of time that fucks us up about our bodies, about food, and about our sort of role in the world. So I think that's one of the major things that makes anorexia different from the other disorders. And it points to the fact that this is why one of the key elements of treatment is to fully weight restore somebody and hold them at a weight restored place as best you can, so that that aspect is nullified to the extent possible. But a lot of these psychological effects were noted to go on a long time after the experiment ended.
How do you think about working with anosognosia when you see new eating disorder patients? So you have someone show up, and let's say he or she is pretty certain that he or she does not have an eating disorder. You're going through the physical exam, and you're finding that they have gastroparesis and they have cold hands, and you're convinced that this person does. Like, what's your general approach to this? And again, this is something I see in my practice a lot in psychiatry. A lot of people come to me and think, I don't really think anything's wrong, and the family's like, something is very wrong.
Absolutely.
But what's your approach to that?
It's one of my favorite parts of my job because there's so many ways one can approach it. One of the joys of my practice is that I get to practice nice and slowly. I get plenty of time with my patients. So I like to slouch down in my chair. You and I are sitting in my office right now, but I like to sort of slump down, put my feet up, and have really relaxed body posture. And as they sit there, stiff, folded in, resistant, cold, and they're like, Dr. G, I'm fine. I don't even know I'm here. I'm embarrassed to be here. Like, this is ridiculous. I'm pretty pissed. I love just being like, tell me more. Because it's so easy as a doctor to think, I know everything. I've got all the answers. You're clearly fucked up. I'm going to fix you. I'm going to show you. I'm going to put in your face how you're wrong and I'm right, and we're going to go that way. It turns out that's not a good approach ever. But it's so often what's perpetrated on patients, not just in mental health, in internal medicine and everywhere.
I think what a feature of addiction treatment is, where like these confronting, like, you got to face it, like, you're fucking crackhead, you're an alcoholic, like, own it, there's in your face and interventions and this, because in a lot of ways, this is a separate thing we can talk about, addictions and eating disorder, like the overlap of that. But yeah, there is in certain realms of psychiatry there and treatment, there's this thing like, you got to just tell people, this is what it is. This is what you have, and you need to like get on board.
Yeah, and it occurs to me as you say that, because you were talking to me about a bunch of the brilliant work you've done, that's probably an example of countertransference sadism. Is that the provider is so frustrated by seeing refractory suffering day in and day out that they just drop any pretense of compassion or patience or slowness, and they just are like, this is what it is. So, instead, I might say, okay, I will write the diagnosis that I think most applies to your situation in the chart. And as an internist, one of my great joys is to help document both the narrative lived and the measurable problems that your body has as a result of behaviors that you're performing right now. But
do you think that gives you more street cred?
It does.
That you're an internist?
Yeah.
Because like, it's true. Like, you've done all this medical training and, even way more than a psychiatrist, like you are like a real white coat kind of doctor.
Yeah,
even
and that's so wrong.
You don't look like that now.
Right.
You look like a yoga teacher.
And this is in fact how I dress every day in clinic. I think that's right. And there is still an unfortunate hierarchy, especially by contrast with sort of, unfortunately, doctors come first and then dietitians and therapists. And don't think the dietitians and therapists in this field aren't constantly being reminded about how they're second-class citizens when they dare to try to teach doctors who don't know about this how to do it better, unfortunately. But, I sit there and I'm like, we don't have to call this anything. What I'm going to tell you is, if you're a black and white striped horse who likes to eat grass on the plains of Africa, I don't need to call you a zebra, but if you get sick, I'd like a zebra specialist to take care of you, and like sometimes I can get a little sort of curl of a smile on that one. And I'll also say, I don't need to name this. What I can tell you is that, because I always start, tell me what your goals and values are. Let's start with your goals and values, because if we do that, I'm less likely to impose my beliefs upon you. So you're the captain of the ship. I'm the wind in your sails. How can I do this in a way that we're focusing on what you want for yourself? And so when I say that and they're like, I just don't understand what the problem is, I'll be like, look, fair. We may just need to have more conversations and get to know each other more, and that's totally cool. But what you told me is you want to do really well in your soccer season this year, and you want your parents off your ass, and you want to be more independent that feels more congruent with your age. Right now, the behaviors that you're doing with food and your body are counterproductive to those ends. So I wonder if you'd be interested in thinking through with me how we might make changes that, while difficult, are feasible to you because you actually want your true goals and values more than you want the restrictive behaviors. Mm-hmm. And we approach it in that way. And sometimes I'll just write to patients, take a trust fall with me. I'm here. One option you have, I love emphasizing autonomy at every possible age. I'll write an assessment and plan after talking with the patient in this way. If after reading this and after our session, you're like, this is not for me, I'm not going to do it, I'm not interested in this dynamic, I don't want to work with you, I don't really want to make any changes, that is your right. As an internist who specialized in this a long time, let me let you know what I expect is going to happen to your body over time if these continue. And let me also let you know that almost no matter what age you are, unless somebody has been really sick for a really, really long time, decades, your loved ones aren't going to let you die from this. So at some point, you are going to lose the ability to make this decision, and someone is going to really assert authority over you, like with a guardianship or something else. So if you want instead, you could take this trust fall with me and we could start doing this work together, and you could see how it goes.
Mm-hmm. I wonder too I love that trust fall metaphor. It seems like that might work much better for people who are, binge purge or just binging. Because again, I see that in my practice, like the people who their eating disorders is largely that. In some ways, they remind me of my addicts. Like people come in like, I really don't want to quit drinking, but I do. Or I don't think there's any way I can stop shooting fentanyl, but I have to. But it seems like my folks with anorexia, it's almost like I say, okay, the treatment is we're going to have to drop you in boiling oil, which equals you're going to have to weight restore. In fact, they might prefer boiling oil, like death, literally. I mean, it's kind of what anorexia is like consciously or unconsciously choosing death over weight restoration. And I wonder, do you approach that the same way with this kind of like, I'm going to just hang with you, knowing that, again, there's often, I think, this delusional quality to anorexia where they cannot see what's happening. Like they're literally going off the cliff and I'm fine.
Yeah. It's really challenging. It's challenging for them. It's challenging for anyone who loves them. It's challenging for their clinicians. I like to use a metaphor called the house on fire when I'm confronted with my first I'm fine from a patient. And the story goes, there's, let's say in this case, a young woman standing outside of her burning house. And the fire department comes screeching up and they go, "We're here to put out your fire." And she goes, "What fire?" And I'm like, "Well, I see the flames. I feel the heat. I smell the smoke." And she's like, "Oh no, if I had a house fire, it would be so hot that the sidewalk would be bubbling. And since my sidewalk's not bubbling, I clearly don't have a house fire." And they understand that she's mentally ill and they go put out her damn fire. And that's what I tell my patients when they're like, "But Dr. G, I'm getting such good grades. But Dr. G, my blood work's fine. But Dr. G, my weight isn't down. But Dr. G, my vitals are fine." And so I just look at them and I'm like, "Oh, house on fire." You are a whole human. And I'm going to insist on seeing you as a whole human, not the conglomeration of your labs and your weight and your vitals. You're a whole human. What you're telling me is that 2 years ago, shit happened and you started changing the way you interact with food and all of the joy went out of your life and became everything. And I get it, dude, but it looks like this is going to have to change. Mm-hmm. So additionally, this passionate feeling of I'm fine. I don't even have an eating disorder. I don't know why anybody's even bothering about this. What I'll tell them is, if I told you that you had a mole on your back, you would not say, like, "I don't have a mole, you have a mole. I bet your mole's bigger than my mole. What the fuck?" Just don't even talk to me about my mole, it's fine. You would be like, "Oh, thanks so much. I should probably go see a dermatologist." So I say, unfortunately, I've done this long enough that I can tell you that the passionate defense of your being fine literally clinches the diagnosis for me. Mm-hmm. And a lot of times patients have, one of the defenses is, I think in some ways that...
Which could feel like gaslighting.
Yeah, right?
Yeah, the fact that you're denying this so vehemently proves that you have it. Which again, I've said the same thing with people too. But then I think ooh, is that an okay thing to say?
Well, I think it is, because it is literally part of the diagnostic criteria. I mean, the distortions of body image are part of it. And there's a degree to which, while one wants to be extremely compassionate and gentle and loving and all of this, you also have to speak truth, because a huge part of every person with anorexia nervosa wants to be told, "You can put this down now. Mm-hmm. You've done enough. That's it. That's it. We're done." And you are sick enough to stop. So in many ways, it's their defense of fearing that at any moment, someone's going to pull the rug out from under them and be like, "Ha, just kidding. You don't deserve support anymore. You don't need this." And a lot of patients fear getting better because they fear that their body will get better before their brain does. And when that happens, they'll be abandoned. before they're actually ready to drop the help, because they know that they need loving, ongoing attachment with their treatment team to really sort of get into a place of wellness. And so the resistance to changing behaviors is, looks like you're okay, which is super validated by our fucked up insurance system, because anytime they're in a higher level of care and they've done 2 weeks of eating the food and slowly gaining weight, insurance goes, yep, looks like you're fine, step you down to day treatment. So they've experienced this before, and then the resistance isn't necessarily in defense of the anorexia. The defense is in service of, I want care so badly, and I want you to stick by me and see that I'm suffering even once I'm not wearing the skeleton suit. Please stay with me. Please see how much I need you. And when you can reassure patients, I'm here. Dude, I'm here. We can be doctor-patient until the end of time. No matter what body you're wearing, I've got you. As long as you want to be with me, I got you. It can just give some space to start to live into a shift in behavior, no matter how scary.
I wonder if we might just talk for a minute about involuntary treatment. I think the most controversial thing that we do in psychiatry is treat people against their will. And there are not many physicians who have to do that. You know, in psychiatry, it often looks like, for example, someone with psychosis. And, you know, as I was told in my training, it's fine to be quietly psychotic. But once you start being a little too boisterous or cantankerous, then you're looking at involuntary treatment. Or, you know, when you get too depressed to bathe yourself and feed yourself, we can put people in the hospital against their will. But I know I've never worked in an eating disorder, residential or inpatient, but I know one of the things that is really controversial and hard is involuntary treatment for, I think typically for anorexia. And I'm wondering 2 things. How do you think about when to move people into involuntary treatment? And if the listeners, if you could just kind of explain what that looks like, because I actually don't know that much about it. I think there's this whole kind of cloistered world of what happens with intensive eating disorder treatment.
Yeah, for sure. Let's talk first about the what, and then let's talk about the who and the how and all the why. The what in Colorado looks like a medical professional or a psychologist determining that a patient appears to have grave disability, which in Colorado, it looks like there's a mental illness that is impairing one's judgment and actions so severely that there is a high likelihood of death that will result imminently. That can happen in a hospital, it can happen in a police visit to the home, it can happen in the clinic, and it can happen at the end or beginning of a hospitalization, often when a patient requests to leave against medical advice and they're really on the brink of danger. And in that case, an M1 hold is placed, which is a 72-hour hold in Colorado, during which time either the individual sort of stabilizes and reconnects and is like, okay, I'm going to do what I need to do to stay as minimally safe, or the clinician petitions the court and says, we need to have a short-term certification, which is a 90-day initial mandated treatment that has to happen in a locked psychiatric facility. That doesn't necessarily mean a psych ward, but most hospitals are considered to meet this criteria, and there's one eating disorder program in Colorado that's considered to meet this sort of designation. And so then that patient, parentheses, as long as they have a payer source, is sent over and they receive 90 days of initial care, and that can be extended. It can also be dropped at any time. Oh, it's so problematic. I mean, there's so many things that are complicated about this. First of all, I've certed people before. I have appeared in court to say, this young human will die without this care, and I'm so sorry to take their rights, because boy, do I take that seriously, but they need to be held here and nourished and medicated until they're at a place that I think they're making decisions from a reasonable, logical place, and then can decide to do what they're going to do. But it's really tough. I mean, If you don't have a payer source, you're not going to get certed. You might have an M1 hold to sort of temporarily check things out, but no one's going to treat you for free.
Yeah. And also, what does quote unquote nourishing them look like? For people who haven't worked in patient psych, or they might think, oh, they're going to make them a plate of food and say, here's your food. But that is not what we're talking about.
Sometimes it is, sometimes it isn't. Sometimes patients want to avoid tube feeding through a little tube that's threaded through their nose into their stomach so vehemently that they'll eat their food because they want to avoid the tube. In the most severe and often, quite frankly, traumatic of situations, patients have to be restrained and tube fed, which is horrifying. I mean, it is assault. It is assault. It is life-saving assault, maybe, in the moment. But I have many patients who will never go back to a higher level of care because of the degree to which they felt that their body was imposed upon and harmed when there might have been other options to have them agree voluntarily to do the essence of what was needed.
Sounds a little bit like what happens in psych hospitals where, at least psych hospitals where I've worked, where if somebody's really, explosive and cantankerous, the nurse, the psychiatrist will order, like Haldol, olanzapine or something, and the nurse will come up and show, like, here are some pills and here's a shot. So we can either do this the easy way, you can take the pills, or we can do this hard way and we call a code and we're going to pin you to the ground and we're going to jab you with this, I've seen that for years and years. That works. But there's some, gosh, that's a hard thing.
It's yucky. It's yucky. And it really, we have to remember that involuntary treatment is not meant to get people to make decisions that a treatment team agrees with, purely. That is not reason enough to take someone's autonomy. Someone has to be legitimately at risk of death with a reasonable expectation with nutritional intervention that they could survive and thrive in order to make it justifiable. And even so, it can be dreadfully harmful. So, what I try to think about in lieu of this is how do we sit in the shit with the patients? I think about sort of a pigsty and they're just sort of sitting there so miserably. And I'm like, let me come sit in the shit with you. Like right next to you, squelch, let's talk. And just be like, okay, yeah, we're getting there. Like we're getting really close to this place where you're at meaningful danger. So what's the plan going to be? And a lot of what we do in our supervision in this clinic is to think about where patients are on the spectrum of, not doing so hot, not really doing worse, starting to be at risk medically for a serious, permanent, adverse outcome, showing now signs that are measurable of that being imminent. Okay, when do we start to really kind of leverage some rules, leverage some power? What I tell patients is, I hate to do this. Let's not have this conversation ever again. But, I'm looking at the X, Y, and Z, and it looks like you are really at risk of permanent neurologic damage or death here. I heard you tell me you do not ever want to go back to treatment. So, we have only a few options left, and you got to show me you are able to change your behaviors at home. You are an outpatient. I see you half an hour once a week at most. So you have to either show me that you can wrangle your OCD and your anorexia and make change today, even though you didn't do it yesterday, and that is excruciating for you, and then progress forward, or we have to talk about what's going to happen next.
Yeah. How many times a year, roughly, do you have to put someone in involuntary treatment?
Never in the outpatient setting. I have had a patient or two who's been in treatment and they wanted to leave against medical advice, and I thought that could really result in danger, and I have represented in court being like, I'm so sorry, I have to be against you. I'm for your life. I'm for the you who has all of these. I'm for the you that has all of these goals in the world, but I'm against your autonomy right now. But I haven't, because usually we have the relationship here that allows patients to recognize, like, all right, it's helpful for me to know that I'm really kind of at that point. Because the eating disorder continues to say you're fine. It looks and says, I saw somebody who's thinner than me on social media. I've heard of somebody who's had a lower potassium level than I have. I'm probably fine. Everyone's probably overreacting. And one of the things that's so powerful about knowing all of the physical things that can happen to someone with an eating disorder is to be like, that is incorrect, unfortunately.
Yeah. I've had a few people over the years come in, and usually not at the initial eval, but within a few sessions, they said, I almost didn't come see you. Do you know why? Actually, now I know why, because it's always the same thing. I say, why? They say, because we Googled you, and you're like some super serious runner. You're going to judge me. You're going to think I'm lazy. You already are probably thinking terrible thoughts about me. And the only reason I'm here is because other people said I should come. And then I figure I've heard that a number of times. So it makes me wonder how many other people are sitting there quite confident that I am just judging them, how terrible that you're not a runner or swimmer. But how I want to segue into this, on the interview with Dave Peter, you talked about thin privilege. I'm looking at the two of us here. We are both thin. We are both athletic. And I'm sure when people meet with you, how could they not? They're doing all sorts of comparison. I'm wondering if and how you bring that into the treatment relationship, the way you look, and, just kind of owning that, because that seems critical.
Yeah, that's a good question. There are patients that I have who feel actively frustrated by the fact that they're sitting across from a clinician who has all the privileges. And fortunately, a lot of them are, empowered enough and so brilliant, and they'll just be like, it's super fucking annoying that I'm sitting here in my fat body and I'm a queer, disabled, fat person with chronic disease, and you're just sitting there across from me. I wish that I had team members that represented me more. And I'll be like, that makes a lot of sense. Yes. And if I can possibly help them to find a therapist who maybe shares some of the elements that they identify with, or a dietitian who does, that can be helpful. And there are wonderfully representative professionals in the field, fortunately, out there, whom we work with all the time. But it's a thing. On the other flip side of that is the fact that I genuinely walk the talk when it comes to believing that people can eat all the different foods and eat plenty of them. And the fact is that if I were a fat person encouraging people to eat everything and, not be fearful of food, I would be looked down on. But as a thin, privileged person, I'm lauded. That's really complicated and yucky. However, it helps my patients when I'll be like, okay, let me tell you this story. Because they'll be like, oh, Dr. G, I ate lunch and then I ate dinner. Is that okay? I feel so bad. I was really torn up about it. And I'll be like, okay. So a number of years ago, my husband and I went to Napa for an anniversary. And we had, gone to one or two wineries. And then we had a picnic at our favorite place. And so we bought a baguette and a thing of olives and some salami and a couple hunks of cheese. And we sat out among the oaks. And it was like 1:30 p.m. And we had this wonderful picnic. And then we had dinner reservations at one of the most beautiful restaurants in the world at 5 p.m. that night. And I went home and I took a nap and I put on my pretty dress and I had my 12-course dinner. And it was fabulous. And I had also eaten breakfast that morning, and I also ate breakfast, lunch, and dinner the next day, and everyone kept their hair on. And so just to know that that exists, there's so few spaces in which people actually interact about food in ways that do not fear it, in ways that don't fear body change, in ways that are like, yeah, I drink my decaf coffee with a huge amount of whole milk and the addition of half and half because I love the mouthfeel of the milk fat. Women don't talk to each other like that. They're always sort of trying to go just under a little bit less, I'm avoiding this, I'm resisting that. And so it's really helpful, I think, in some ways for my patients to see that even though I have thin privilege, I also have a strong, sturdy body. And I do hug my patients because I'm not a mental health professional, and I love that.
And you're a woman. I think that's safer.
Also,
yeah.
and of course with consent only. And when they squeeze me, I'm a substantial person, and I think that feels good too. So I think as a role model, having one's body in the room can be a positive.
I want to talk a little bit about what physicians and therapists do well and don't do well, and what we say well and don't say well. Let me just open with an anecdote. And I've been thinking about this this meeting with you for many weeks. But one thing I just want to tell you, which I'm curious what you have to say. So before I do ketamine treatments, I weigh everyone. And I don't know what made me think this, but when I started doing this years ago, I just thought I should ask everyone every time, do you want me to cover the scale? And still it's about 60% of everybody wants the scale covered. And I know these patients really well. Very few of them that I know of have eating disorders or body dysmorphia necessarily, but when I ask them, do you want, maybe 2/3. And so when I have nurse practitioners rotate with me or med students, I always say, check this out, because this is very interesting. Like I'll say, we're going to have 5 ketamine patients. I bet you at least 3 won't want to see the scale, and none of them, to my knowledge, have any body stuff. So that just makes, so again, I hear a lot, people, I went to the primary care doc and I saw my weight and it ruined my whole week. So maybe that could be an entree into what are we doing well? What do we need to be doing, and what should we not be doing clinically?
Ooh, there's so many things to say. Where do I begin?
Top 5.
I'm so grateful that you offer that to patients, because very often it is something that chills a patient's willingness to receive a treatment like ketamine, because even if they're blinded in the weight, the number's left out on a sheet of paper and they see it anyway, or they see it in their chart. Of course you have.
Crushing. So now I hide the sheet. I hide the sheet, yeah.
Yeah, I mean, when it happens here, I really feel like an asshole because, we really theoretically know what we're doing on that. But yes, it happens here too. Look, weight is a measurement in our society that has become synonymous with goodness, worthiness, and capacity to walk in the door of halls of power and be safe. So even when people don't have eating disorders, the notion of their weight is still with them essentially on a daily basis, because they're so aware of the power of thin privilege and of fatphobia in our society, and how it's sort of become the national religion, regardless of whether one also carries another one or not. As far as sort of, instead of prayer, it's what are you eating? And your worthiness and your piety is measured by the thinness of your body. So of course it just carries a huge amount of power. And even I, who maybe get weighed once a year at my OBGYN for my annual appointment, I don't love seeing it. I've never had an eating disorder in my life, but it can make me feel a little wiggly afterwards. And I am about as healthy and balanced and even-keeled on this topic as any human with, my degree of education and experience in the world could possibly be. So, I mean, one of the common things that mental health professionals do is not recognize the work that they might themselves need to do separately in therapy or in supervision about their fatphobia and about their beliefs about bodies. So, for instance, a really nice non-eating disorder therapist might have a patient walk in the room, and she might intrinsically, automatically say, "Oh my God, you look great today." And the patient was maybe engaging in disordered eating and had lost a few pounds, because weight loss has become synonymous with an appearance of looking good. I've had many patients who have told me, just sotto voce, barely able to express it, that their parent on their deathbed looked at them and said, often their mother, "Well, I'm dying of cancer, but at least I'm thin now." And that was some of their last conversations that they had, So trying not to engage with patients' diet culture is really important. At least staying neutral. If you can't be fat positive, and our clinic specifically designates itself as a fat positive clinic, but being weight neutral. So, hey, I lost weight. I'm so excited. What does that mean to you? Mm-hmm. Tell me about that. Doc, I gained weight. I'm freaking out. Okay, I'm here for you. But it's so interesting how often clinicians will talk about their own weight, their own diet, their own recent, gluten-free life, because it is, like I said, it's water cooler talk. So trying to stay weight neutral in one's conversation and not ascribe positivity to a certain body appearance is a really wonderful starting point for clinicians.
Can I ask more about that? So actually, I just had this conversation this week with a patient, and I was thinking about you, and I thought, gosh, I want to hear what Dr. G says. So one of the things that we, meaning, let's say psychiatrists or psychiatric clinicians, have to do, and it's a really difficult thing to do, is talk about psych meds and weight gain. Because most of the very best psychiatric meds tend to cause weight gain, and some cause a lot of weight gain. So, I find myself, say I'm starting somebody on clozapine, or one of the other atypical antipsychotics, and I'm starting off saying, this has metabolic effects. This can be a weight gainer. This could push you towards diabetes. We need to really be on top of weight gain because that can push you towards type 2 diabetes, that can push you into sleep apnea. So this week I had a conversation with a patient who just hit 300 pounds. She brought that up and she said, I just hit 300 pounds. That's really scaring me. So what advice would you give me and other listeners when, because I talk about weight a lot with people, not as much as weed, but I would say weight is a top 5 thing I talk about because, again, psych meds cause, even again, not necessarily for people with eating disorders, just psych meds, especially in women, are big weight gainers. And so I want to be as sensitive and thoughtful and non-wounding. So do you have any thoughts, advice for me around that?
Yeah. Holding space for a person's experience of their body with compassion and without judgment is so important. So if I were in your situation and the individual said, I just hit 300 pounds and I'm freaking out, I would be like, tell me about it. Tell me what meaning you're making of that. What does that mean to you? What does it mean to you now? How is it affecting your life? How does it harken back to what you heard about bodies and fatness growing up? Tell me about it. Because it could be easy for me to make an assumption about what they don't like about that, and it might be completely different from what they're actually worried about. So that's one of the ways that we can check our thin privilege and just give them an opportunity to share the experience. Tell me about it. Secondly, I'm fortunate because the meds that I prescribe do not cause tremendous weight gain. And so I'm not in the situation that you have to be. It's a really, really hard situation. I believe that part of my fierce dedication to patient autonomy involves really comprehensive work around consent and understanding risks and benefits. So being extremely clear, we've got a situation where you have psychosis and you've tried these 4 different meds and you've told me that it's ruining your life and you're about to lose major relationships or profession or whatever it might be. The med I have left that I think has a 50% chance of improving your psychosis to where you could function on terms that you feel are important is not unlikely to cause you to gain 25 to 75 pounds. We're in a really tough spot. This fucking sucks. We are between a bad choice and an equally bad choice. Could we talk through what the implications for you might be if we treat or don't treat?
Yeah.
And I think that that's what I would do. And some people might say, I'm going to need to go on some cocktail of meds that's worked only moderately for me, and I'm going to have to try to do all of the behavioral mod that I can possibly do in order to, stay as functional as possible. But, I can't go through what that weight gain looks like. And other people are like, absolutely, I'll if I have to gain the weight, I have to gain the weight.
Yeah. Or I think it may be a more realistic conversation, at least that happens in my office, is we're going to start this med. It's very, very commonly can cause maybe a lot of weight gain. So we're going to aggressively treat you with metformin or there's some other strategies too. So I might say something like, we need to keep a close eye on your weight to see if the metformin is preventing weight gain. Because if you start metformin immediately, there's a lot of good research that shows that you can prevent the weight gain. If people have already gained the weight, then metformin tends not to bring it off. But now I've started having, it's just now happening, this is the new frontier. Some of my people who are about to start like clozapine or olanzapine, I'm like, there are these GLP-1 agonists, the Wegovy, Ozempic. And then I'm thinking I'm thinking of this conversation with you, like, what would Dr. G say? I'm sitting here saying, we're going to put you on clozapine. This is a big weight gainer, so let's just also put you on GLP-1 agonists now to prevent, I don't know, it's like weight is such a big part of what happens in psychiatry. We talk about it all the time.
Are there studies yet on whether the GLP-1 agonists combined with the serious weight gain drugs work? Do we know anything yet?
No, we don't. It's too early.
Surely someone's doing that work.
Yeah. I think now that just access to those meds is so difficult. I have a handful of people doing it. Yeah, so now I'm doing more metformin, but it's coming soon because they're going to be generic in a few years, and we'll be able to say, hey, for your treatment-resistant bipolar disorder, here's clozapine, and here's the new improved. Yeah, I just think it's so complicated because we want to be weight neutral, not fat shaming, not fat phobic. Yet, for a number of my patients, we talk about weight and weight gain all the time.
Yeah.
I always try to couch it, which is not just couch it, talk about, look, why am I concerned about weight gain? Because sleep apnea and because pain and blood pressure and type 2 diabetes. And I'm always hoping that they're not thinking, oh, and you just don't want me to gain a bunch of weight and get fat.
Yeah. Well, I think it's important to remind patients that fatness is not a failure of willpower. Fatness is biological. Fatness is genetic. It is not necessarily related to adverse health outcomes, although it can be. There's lots of other things that come with thinness that are associated with adverse health outcomes. And that one's early exposures to restrictive intake, whether that was because your mom put you on a diet when you were 8 or because you had food insecurity, those all mediate what our bodies look like. And it can be easy for people who are thin privileged to be like, I just live my life and I walk around in a body that's completely acceptable by society. So that must be how everyone can be. And the truth is that's just not the case. So, we might want to talk about, I'm going to give you a medicine that is going to make you gain weight. It is going to be irresistible to gain weight. You won't be able to help it. You're going to eat the same way you always did, or you will be so irrevocably driven towards hunger because of this medicine that you're going to gain weight. Let's talk about what that looks like. Let's talk about whether there are things that might mitigate that. I, of course, don't use the GLP-1 agonists in my practice for a variety of reasons, but I can imagine a world in which you say, you're dealing with a lot of stuff in your life and you have a family history of diabetes and you've told me you really want to avoid X, Y, and Z. It looks like the only med I can prescribe you to give you a quality of life that's acceptable to you is going to push you into the arms of that. Maybe we need to think about some off-piste options here, like a GLP-1 agonist. And I don't have judgment in that situation. I would be foolish and thin privileged ideologue to stand on a soapbox and be like, no one can use those. No one should seek weight loss. That's nonsense. That's completely unfair. We just have to go slowly and we have to think through it slowly. And we have to recognize that patients gain weight for a whole variety of reasons, most often in our country related to not eating enough. Because when we don't eat enough on a diet, on a fast, our body gets the message, hey, you'd better eat more and put on a little extra when we come out of this famine, because that is how we evolved. So most patients will find that if they actually eat more and consistently and perhaps move their bodies in a way of bringing them joy, their weight will do what their weight's going to do, and that's just the way to be healthy regardless of what your body looks like.
I've recommended bariatric surgery to a few people over the years. It's been really life-changing for a few of them. It's such a hard thing to bring up, just because I brought it up unilaterally with a few people. I'm curious what your thoughts are on just bariatric surgery in general, and if it is something you or other physicians should occasionally talk about, like how do we talk about it?
Mm-hmm. Look, on the whole, I'm not for it, because I feel that there are a lot of elements to it that are that systematically put patients at a disadvantage. One, it's a massive moneymaker for the industry. And so anything that makes that much money is going to be under scrutinized. Many patients that I've seen weren't really screened at all, except for on the most minimal level, for an eating disorder prior to getting gastric bypass surgery. And they had an eating disorder, and they were not psychologically appropriate for it. And so that is one, sort of the pre-screening process is deeply inadequate. Two, the surgical procedure is so barbaric. It is punitively, strangely barbaric. I mean, the stomach is left with like a 30 cc pouch. That's an ounce. The stomach is an ounce. I'm just sitting here drinking my water that's probably got 12 ounces in it. Why does it have to be that punitive? It feels like a punishment for fatness. Why would the surgeons pick an ounce? Who can possibly nourish themselves and have satisfaction when that's the size of their stomach? And then when it comes to Roux-en-Y, we're also inducing malabsorption, which causes all sorts of GI distress. And it's irreversible too. This is not something that you can try out and then be like, well, maybe it's not a good idea. So I tend to think that the industry is problematic. I, of course, hold that as bell curves go, there are going to be half of the people to the right side of the bell curve who have satisfactory and helpful results. And so what I never want to do is shame somebody for having chosen that, or shame a clinician for having, with good cause, suggested to a patient, look, it looks like we're at the point where this is a good idea. That may be the case. Mm-hmm. And I very much believe that there can be extreme cases where, in the same way of forced treatment, maybe for life-saving purposes, mm-hmm. we accept life-threatening or very, very punitively challenging solutions. Yeah. I just think that, especially with the GLP-1 agonists being a very different alternative to meaningful weight loss at this point, even though, again, that's not my practice, I would certainly go that route well before I would go permanent anatomic change. Mm-hmm.
Yeah, for me, I think the few times I've recommended it, it was largely around just severe, not treatable sleep apnea. Because I'm definitely a true believer that the foundation of psychiatric psychological health is sleep. And I just see in my practice that people with really severe, hard-to-treat sleep apnea, they can't get better psychiatrically. They just can't. It's like they're being tortured every night with sleep deprivation. And it is pretty astounding that, if people can lose a significant amount of weight, like their sleep apnea very often just goes away. Like it just disappears.
Look, there's no doubt that a lot of metabolic problems get a lot better with weight loss. Some don't, and a lot do. This has been the basis of a lot of extremely well-meaning, terrific clinicians becoming weight management specialists. The problem is that biologically we resist weight loss. The mm-hmm. human species resists weight loss because that is how we evolved. It is as inevitable as trying to keep ourselves from taking the next breath. It is deeply plumbed into us. And so when my patients, who might have atypical anorexia or bulimia or binge eating disorder come to me and they're in very large bodies and they're like, Dr. G, I have sleep apnea, I have diabetes, I have hypertension, I have high cholesterol, my knees hurt, I can't walk around much, I'm deeply stigmatized by the world. Don't you think I should lose weight? And I'll say, I sure can understand why weight loss would be helpful. But I don't have any belief that there is a system that can allow that to happen consistently in a way that's congruent with mental health and sustainability. So instead, let's focus on strength training. If it starts in a chair, great. Let's focus on building muscle, because muscle mass is an insulin sponge. It helps with glycemic control, completely neutral of weight loss. Let's maybe, as you get a little bit stronger, let's work on other kinds of weight training so that your mobility gets better. And as that happens, maybe you start to be able to walk a little bit more. I mean, I have a case series of patients that I've been planning to publish for so long, and I have not managed to finish the manuscript.
You just got to finish that whole song.
Yeah.
It needs a chorus and a bridge, and then
It really does. It really does. So this case series of patients was a very interesting group that showed up in the first couple of years I was in this clinic. They referred each other because one or two of them had come to me because they'd been part of this online scam in seeking treatment for their atypical anorexia, typically, where the scam artist said in this community, you have to eat 5,000 calories every day, regardless of hunger. You may not move a muscle, or I will consider you to be excommunicated from this community. And you might gain weight, but if you do it right and you stick to the plan, your weight's going to settle out properly and you'll be recovered. Now, I guess in some rare cases, some people have had a good experience with this. But for the most part, my most beautiful, rule-followy, delightful, yummy patients just kept eating 5,000 calories a day, including drinking a carton of cream at night before bed to get in their calories by the end of the day. And not surprisingly, their health was markedly worsened by this. And they had all gained an enormous amount of weight and were really metabolically in rough shape. And so when they came in, fortunately, they had gotten beyond their restrictive stage. They had actually, in interesting ways, the only positive to this, but it should never have gotten this extreme, they had healed their metabolism of its restrictive low. But what I said to them was, I'm never going to weigh you. I care about your weight only in as much as you care about how it is to live in your body, and I will hold space for that. But I'm going to say, don't count calories. I want you to just, stop forcing calories, but eat a hearty breakfast, lunch, and dinner, whatever satisfies. And let's start getting some movement in ways that your body is able to. And some came in barely able to take 3 steps before they needed to sit back in their wheelchair. And over the course of a year, and 5 of the 12 patients had very high insulin-requiring, insulin-dependent diabetes, 200 units a day kind of a thing. By the end of about a year, I think the mean time was 14 months, where they had a body-positive dietitian and a good therapist and me. Nobody had ever weighed them. All 5 patients with insulin-dependent diabetes no longer had diabetes mellitus. It was gone.
Wow.
And all of them were radically mobile again. And, one of my patients was like, I got to walk up the 6 flights of stairs at the Taylor Swift concert with my daughter again. It was amazing. This was no weight, no diet, no focus on weight. It was a focus on listening to your hunger, satisfying it, and beginning to enjoy your body and the world again. So the fact is that one can accomplish pretty remarkable things not focusing on weight as the primary outcome, because that's likely to sort of be a bust, but instead focusing on moving one's body more in order to find better health.
Yeah. We touched on this before, but I just wanted to read this quote because I love this. This was from your interview on Psychiatry and Psychotherapy podcast. You said, quote, orthorexia has become the religion of the populace. Following food rules means moral superiority in our culture. I wonder if you might say more about that.
Yeah, it's just the sad truth, isn't it? That we no longer really are operating along a code of honor, ethics, compassion, thoughtfulness to others, a sense of what's more or less right to do. A lot of people's first thought is, am I restricting enough? Am I eating clean enough? Am I working out enough? And I get it. I don't have judgment for the individuals choosing those things, because the power that can accrete, the power that can emerge from that is so astonishing that I get the motivation. But what have you won? Like, show them what they've won. You've won a long life where you don't eat in ways that bring you pleasure. You always feel gnawingly hungry. You feel nervous about food, and you're constantly preoccupied with what did you eat and what will you eat. That is not a great quality of life. And I would just welcome people into a different mentality, which is, what if I learned again how to acknowledge when I'm hungry and how to decide what I'm in the mood for and nourish myself without doubt or guilt, and then trust that my body will use that nourishment in a way that's reasonable. and go enjoy my life. You know, I mean, there's just so many people who have lots of resources and who don't have absolute impediments to some of these joys. They're living very small lives because these are the rules that are guiding them, and their lives could be so much more luscious and full and interesting and varied and spontaneous than they are now.
Yeah. Yeah. One of my food rules is if I see a Dairy Queen and I have any ability to stop, I'm going to stop and get a Blizzard.
Fabulous. That is a great food rule.
I was driving my little teardrop trailer across Nebraska a few years ago with a dear friend, and we saw Dairy Queen. It was like 10:05 in the morning. And I said, "Is it too early for Dairy Queen?" He said, "It's never too early for Dairy Queen."
That's it. That's what we have to model for each other. Not this sort of like yucky, subtle race to the bottom of sort of, I abstained better than you abstained yesterday. You know, it's not as if it's something that people take active pleasure in for the sake of it per se. And in many cases, it distracts them. It's a numbing strategy. It distracts them from other stressors, etc. But the reality is that our bodies are extraordinary. We are the largest mammals on Earth that can be omnivores. I mean, whale eat like krill. That's it. Or plankton or whatever. You know, giraffes eat acacia shoots. They have these very limited diets. But humans are the off-roading machines of the nutritional world. We can eat almost anything, and as long as we have basically the right amount of stuff in it, we're going to turn a kid into an adult. That is phenomenal. Why give that up? Why cede that to a set of rules that are so limited?
I mean, we even eat pickles. There can't be any other mammals that eat pickles. Ugh. Listeners know I have serious pickle issues, and I have condiment issues too. Let's finish one last topic, and this is something that's very dear to me, and I think dear to you, and it's, again, such a complicated issue, and it's exercise. I tell my patients a lot. I've actually said this to them, I am a true believer in at least three things in terms of your psychiatric health. I'm a believer in sleep, I'm a believer in love, and I'm a believer in exercise. And I also know that the latter, the final one, for folks with various eating disorders, that can be a very loaded topic. So I wonder how you think about exercise and eating disorders, and I know you're a big believer in movement, and how do you talk to people about exercise, and how do you help people not go overboard and just use that as another kind of restricting strategy?
Yeah, love it, because our clinic likes to be a real maverick on this. The eating disorder field historically has told patients who have a history of overexercise or a history of, a bunch of different eating disorder behaviors, don't move. Don't move. You'll be in your eating disorder. Just don't do it. And that's so confusing, because the same clinicians are trying to convince patients not to think that exercise is for burning calories, but then they're like, don't go for a walk. You're going to burn calories. Wait, which one is it? And in our clinic, we deeply believe that movement is part of life, and that movement on terms that patients set towards ends that they set helps to shift their whole identity back towards somebody who is a body doing things in the world and not a body who needs to judge itself for having needs. Shifting to athletic identity from eating disorder identity is such a positive way of moving somebody forward. So, the first thing, again, is ask. Don't make assumptions. I have elite athletes in my practice who are not in emaciated bodies and who have meaningful eating disorders, who have gone to see a subspecialist, and the first thing the nephrologist tells them is, have you thought about diet and exercise? And they're like, bitch, I restrict all day long and I work out for X number of hours a day. So, don't make assumptions based on somebody's body. Ask. Tell me about your relationship with movement. Not only what do you do, What have you done? How has it felt psychologically? Tell me about the whole situation. What are your feelings? And then the next question.
That's a great question. Tell me about your relationship with the movement.
Yeah.
I love that.
And then what do you want? That's the next question. Because I might think, let's get you strong again. Let's do all this fun stuff. And they might be like, I need a break. I just need to take some time. So ask, what do you think you want right now? What would feel good right now in your body? Once you have sort of the essential medical stability, once you have the essential fueling of your body to go do things, do you want to start being active again or do you not? And what would that look like? What do you hate doing? What is sort of intriguing to you? What's typically triggering to you? I certainly recommend that people get rid of all of the external loci of authority over their movement. So no Apple Watches, no like monitors.
No Strava.
No Strava. Like the internal locus of authority is, what do I want to do in my body right now? Mm-hmm. How fast, how hard do I want to go? How long do I want to go? And not because I made a plan and I'm going to stick with the plan, but I'm going to listen to my body. And yeah, I can push. It can hurt, but I'm going to know what's right for my body. That retaking of internal locus of authority is a healer for eating disorders, for trauma, being given permission, ironically by an external authority, me, to listen to your internal authority can be very, very therapeutic. I'm a really big fan of strength work. I really think that it's accessible to people of all ages and body sizes and abilities because muscles can be strengthened almost regardless.
And how do you coach people to start strength work?
Yeah, so I know just enough to get them started. I do work with one particular fabulous doctor of physical therapy in Denver who specializes in reconnecting people in recovery from eating disorders with movement, which is like amazing. She's such an incredible resource. I can give you her name. I've learned a lot from her as well. And what we sometimes say is like, what would be fun and what might you do that's varied? One of the things that this great PT does with her patients is let's put 10 different activities in a jar. 30 minutes of yoga, 15 minutes of upper body strength, a 15-minute walk, and you just pick one out each day because that helps the OCD that says if I didn't do it yesterday, I can't do it today or have to do it today. Let's just be a little spontaneous and start doing things in our bodies. There are great therapists who do this with patients, and there are great therapists who also are athletes who sometimes do things with patients. They'll have sessions while walking or while running, and they might say, hey, we're just going to stop for a second and check in. Are you still with me? Because you look a little dissociative. Are we here or are we somewhere in our head judging ourselves? Because let's pause and take a second. Or let's journal afterwards. Were you present? Were you enjoying the feeling of the ground beneath your feet and the breath in your lungs? Or were you lost in your head wondering why you can feel your thighs jiggle? Where were you there? What's so fun is that then fueling becomes about giving your body what it needs in order to do fun stuff, not about this punitive compensatory spiral that so many patients get into. I love this story of the modern Hadza nomadic people in North Africa that were studied by a group of scientists who sort of wanted to prove the hypothesis that these virtuous folks who walked 10 miles a day in the course of their hunter-gathering burned way more calories than the average American couch potato. And so they did this very rigorous metabolic study for a couple of weeks, and they found to their complete astonishment that they burned exactly the same number of calories. And they were like, literally laws of thermodynamics, how is this possible? And it turns out that, of course, when our body is moving through space, it takes fuel to move it. But if we're not fueling the movement and our underlying needs, our metabolism will just slow and slow and slow. So all of the food we eat goes towards the movement, but we're burning fewer and fewer calories a day. And this has a name. It's called relative energy deficiency of sport, or REDS. This is a beautiful description. The International Olympic Committee end of last year came out with a great new article that summarizes the new REDS criteria and how it manifests. But it basically sums up what I do every day. It's what are the physiologic and psychological manifestations of underfueling. And these aren't in the context of an eating disorder. This is just, whoops, I didn't realize I needed to eat X amount in order for my body to do this. So what I tell my patients is, not in the 90s where you get on your Stairmaster and you burn 250 calories and now, yay, you've succeeded. You have a 250 calorie hole in your day. Nonsense. If you're not eating to fuel that so-called 250 calorie workout, whatever that means, because usually those numbers are just nonsense, then you're going to slow your metabolism by 250 calories that day because your sweet, miraculous, perfect body is just trying to take care of you. So if you had fed the Hadza people a buffet as they walked along and they were eating 4,000 calories a day, probably that's what their metabolism would have burned. But they spent the 2,000 they were able to eat that day on moving and probably had colder hands, colder feet, slower digestions, perhaps lower fertility rates, because that's what the body does. Mm-hmm. So fuel your movement. Movement is not to burn calories. Movement is to be strong and enjoy nature and to do things and to be independent and to have fun.
Yeah. I had not put this together, but this makes total sense that sometimes after I've done a really big multi-hour run or some of these destination adventure runs that I do with my buddies, I mean, I never get cold. I run like hot all the time. But after those really big runs, I can get so cold. And I think I've just in this huge energy deficit. My body's like, yeah, we got to turn all of the calories, And it's only after I eat just a phenomenal amount of food do I warm up.
Perfect.
Yeah. Okay, well, we should wrap up. And I got to pull out my phone and see if there's a Dairy Queen anywhere nearby. Because now I'm sure maybe on Colorado Boulevard.
There is. There is? Just on Colorado. It's really close.
Yeah, okay. I mean, I think I deserve it. I've been burning calories here talking to you.
You deserve it whether you've been burning or not.
I know that. Even if I were in a hammock right now, I'd be like, no, I want a big blizzard. Yeah.
Correct.
This has been so great. I'm so glad we could make this happen. And thanks for sitting down with me.
Thank you so much for the opportunity. This was amazing.
Yeah.